buenos días o buenas tardes a todos los que están hoy acompañándonos. Tenemos nuestro último webinar del año de Cochrane Colombia. El día de hoy, como director de Cochrane, me place presentarles a mi compañera y amiga, Tahira Devji, quien es un Resident Physician Internal Medicine en el Departamento de Medicina de McMaster University, cofundadora y co-investigadora principal, co-investigadora de la iniciativa PROMIT, de la cual le hablará más tarde, y quien hace parte como co-convenor del Cochrane Pro Methods Group. Tahira nos acompaña desde Hamilton, Ontario, Canadá, y nos va a hablar hoy de la diferencia mínimamente importante, su importancia en investigación clínica, en la síntesis de evidencia y en las guías de práctica clínica. Entonces, voy a dar unas pequeñas instrucciones acerca del procedimiento. Tahira tendrá aproximadamente 30 o 35 minutos para hacer su presentación. Posteriormente, escucharemos preguntas de parte del público que está aquí, que las deben hacer por medio del chat. Nosotros las recopilaremos, pueden hacerlas para facilitarles el proceso en inglés o en español para la lectura, para que Tahira las pueda resolver en los últimos 20 minutos de la hora que tenemos a disposición. Agradezco a todos los participantes del día de hoy. Recordemos que esta presentación quedará grabada y quedará disponible posteriormente en la página de Cochrane Colombia. La presentación, reitero, si no estaba del todo claro, la presentación de Tahira será en inglés y le voy a dar el micrófono ahora. Tahira, hi. Very nice to see you. It's a pleasure as a colleague, as a friend, to have you here in the Cochrane Colombia webinars. Just introduce you. The mic is all yours, and we will be happy to hear your confidence and then try to resolve some questions that the people may have. I will be here taking notes and collecting the question with Pamela, who is also part of Cochrane Colombia, who is here with me. Let's see how it goes. And thank you so much, Tahira, for joining us today.
Thank you, Ivan. Thank you for having me and for the warm introduction. Buen dia. Good morning, everybody. Thank you for attending. Today, I will be speaking about minimal important differences, their importance for clinical research, evidence synthesis, and clinical practice guidelines. As Ivan has already mentioned, I am the co-founder and principal of PROMID, which is a health status measurement, research, and consultancy organization. I will be presenting some of the work related to PROMID as it's relevant for this topic today. The objectives of today's presentation is to really communicate and understand the value of patient-reported outcomes as key patient-important outcomes and considerations for outcome measure selection in systematic reviews and in guidelines, to demonstrate different alternative approaches with the emphasis on using the minimal important difference for enhancing interpretation of patient-reported outcome measures in clinical trials and systematic reviews. No two MIDs are created equally, so it's important for us to distinguish between credible minimal important differences and those that are less trustworthy when we are using them for interpretation. How to select an optimal MID, which involves assessing credibility, but also contextual factors when using the MID. And then finally, applying evidence synthesis methods relying on the MID to improve presentation of patient-reported outcome measure results, systematic reviews, and clinical practice guidelines. It's always helpful to talk about methods issues around a case to illustrate. So I will be referring back to a case, and this is a real example where we utilize minimal important differences to enhance the interpretation of PROMs in a clinical practice guideline. Throughout the presentation, I'll also use various different clinical examples, but the presentation will surround this particular case. So just a brief background on degenerative knee disease or osteoarthritis of the knee. So it's a very, very prevalent condition. 25% of people older than 50 experience knee pain from degenerative knee disease. There are various different management options, ranging from conservative treatment and then operative procedures as well. a very common procedure done, arthroscopic knee surgery, is very commonly done and is not without risks and burden or economic burden. There were several clinical trials that suggested the benefits of arthroscopic knee surgery may not actually outweigh the burden and the risks. Despite this, as I've mentioned, it's a very, very common procedure, and globally, this procedure is done more than 2 million times each year and costs about, on average, $3 billion per year to the healthcare system in just the United States alone. So with all this new evidence coming out from clinical trials suggesting that actually arthroscopic knee surgery may not be as beneficial as what we once thought, this called for a clinical practice guideline. Some of you may be familiar with the BMJ Rapid Recommendations, an initiative started between the BMJ and the MAGIC group, which is a group out in Norway and stands for Making Grade the Irresistible Choice. They, as a group, decided to start developing these clinical practice guidelines called Rapid Recs that take approximately 3 months start to finish with a very focused clinical question for a clinical practice guideline. And typically are topics that that address timely topics where there's practice changing evidence available. So the clinical question at hand for this guideline was looking at people with knee osteoarthritis or degenerative knee disease, comparing arthroscopic surgery to conservative management. So just a brief word about patient-important outcomes. So we can only be sure of a change in a patient's health status if we measure the right outcomes. And this is particularly relevant in the context of conducting systematic reviews and, of course, conducting clinical practice guidelines to inform clinical decision-making. Historically, physiological or lab-based or even clinician-based assessments, as well as mortality and morbidity, have been the focus of outcome evaluation and research and practice. However, more recently, with the emphasis on patient-centered care, in addition to evaluating patient-important outcomes such as mortality and morbidity, patient-reported outcomes, and these are outcomes that evaluate symptoms, function, how people feel, their quality of life, are increasingly being used to evaluate the impact of disease and the effects of treatments. Ultimately, in a shared decision-making context, the goal is to be able to provide patients through these outcomes that they will live longer, but they'll also feel better. So we've really seen an uptake of the use of patient-reported outcome measures, both in clinical research and clinical practice. So how is this relevant for this guideline? Well, when conducting this guideline and putting together the guideline panel for the comparison of arthroscopic knee surgery to conservative treatment for degenerative knee disease, the guideline panel members, which included patients, identified 3 outcomes that were most important for patients with this condition. And they happened to be pain, physical function, and quality of life. There were a few other outcomes, but these were the 3 most important patient-important outcomes, which happened to be patient-reported. So how do we collect this information? We do that by using a patient-reported outcome measure, which is a questionnaire that typically asks patients about how they're functioning and feeling. So by definition, a patient-reported outcome is any report that's coming directly from patients without interpretation by physicians or anyone else for that matter, about how they function or feel in relation to a health condition or its therapy. And these, again, measure aspects of health status that are relevant to quality of life. These outcomes inform shared decision-making, pharmaceutical labeling claims, guideline development, and health policy. So just a brief word further on terminology. A patient-reported outcome, you can see on the left-hand side, is information on the patient told by the patient without interpretation. And a PROM is an instrument. So if an example of patient-reported outcome is depression, the PROM is the instrument that is going to be used, such as the Patient Health Questionnaire, the PHQ-9, which is a standardized a way to assess depression. So it's important to distinguish between these 2 terms, recognizing what the outcome is and what is the instrument that's being used. There are different patient-reported outcome measures. We've categorized them into 4 distinct categories: generic health profiles or utilities, such as the SF-36, some of you might be familiar with, or the EQ5D, as well as disease or condition-specific instruments, function-specific instruments, and symptom-specific instruments. So what are the importance of patient-reported outcome measures? I think I've already made a bit of a case for why they're important, but a few other reasons. Well, they measure, there are direct measures of survival, feelings, and function. They're information coming directly from patients. They're not surrogate outcome measures, such as, a measure of FEV1, how to measure a respiratory status in a patient, or tumor size in patients with cancer, where relationships to a direct measure is either assumed or demonstrated. And so it's always important and critical when using biomarkers or externally observable patient-important outcomes, when they are unavailable, that we can use and rely on patient-reported outcome measures, especially when these other types of measures are likely to be biased or rare. And this is where patient-reported outcome measures can be extremely helpful. So for systematic reviewers, for our context here, in the context of conducting Cochrane reviews, where do these outcomes typically appear? Of course, in summary of findings tables. These outcomes can typically be dichotomous or continuous outcomes. The focus of today's talk is really on patient-reported outcome measures that are continuous outcomes and how we can interpret them and assess the certainty of evidence. So before we can start thinking about patient-reported outcome measures and systematic reviews, we really have to understand patient-reported outcome measurement in trials. Of course, we conduct systematic reviews of observational studies as well, but the focus here is about, I will focus here on clinical trials. And it's important to understand PROM development and assessment in trials before we start synthesizing that information in systematic reviews. eSpore, which is an organization focused on outcome-related measurement, has developed this guidance document according to a framework that the FDA has published on patient-focused outcome measurement in clinical trials. And this framework outlines each step in the process for understanding the effects of a treatment, taking into account the condition of interest, as well as the desired outcomes from the patient perspective, and incorporating this knowledge into the selection, adaptation, or development of appropriate outcome measures that are meaningful and important to patients. So this framework will really give us an understanding of the process that goes into outcome selection, and when outcomes are not available or outcome measures are not available, outcome development. Further to this, many of you will be familiar with the CONSORT statement, which is a reporting guideline for randomized controlled trials. CONSORT developed an extension on patient-reported outcome endpoints, and this certainly has helped standardize the way in which patient-reported outcome measures are presented in clinical trials, which will help systematic reviewers when collecting information and synthesizing information. So several of these efforts have actually been incredibly helpful to help systematic reviewers in being able to find relevant information and synthesizing this information appropriately. Sometimes when we're conducting a systematic review, we may see multiple patient-reported outcome measure instruments measuring the exact same construct in a single trial. So although we have all this guidance to help us present patient-reported outcome measure information, sometimes things get a bit challenging when looking at primary trials that are included in a systematic review. And so these are some of the considerations that we must think about when conducting systematic reviews, evidence synthesis, to inform guidelines as well. So you might see that trialists are using multiple different instruments measuring very seemingly similar constructs or the same construct. In this case, the example here shows that there are multiple different instruments evaluating physical function. So in this case, we have the WOMAC physical function, we have the SF36 physical function component score, as well as the ASES function, and then the MACTAR. These are all different patient-reported outcome measures that are evaluating the same construct function. And so when there's no consensus on which instrument to use, or when these different measures are measuring slightly different aspects of functioning, for systematic reviewers or people conducting evidence synthesis, this poses a particular challenge. So we need to think about what is going to inform the choice, and I'll go back for a second here. What is going to inform the choice of selecting one row of data to include in a meta-analysis in a systematic review? Of course, we're not going to pick the results that look the best or that favor the message that we want to tell in our systematic review, but rather we're going to look at the constructs, looking at the patient-reported outcome measures themselves, understanding exactly what is it that they're measuring. Does what they're measuring actually match the intended construct of physical function for your outcome in your systematic review? And that can help inform the choice of which results to use. We would also look at the measurement properties. I'll speak about this briefly in another slide, but measurement properties refer to reliability, validity, as well as responsiveness of a measure. So how credible are these measures and how credible have these measures been created? Sometimes it's helpful to know what is the most familiar instrument. So if all these instruments are evaluating the same construct and they all have excellent measurement properties, then perhaps you're going to use the instrument that is most commonly used in your field of study. And then lastly, have there been metrics or some sort of a benchmark to enhance the interpretability of the prompt? So if an MID, which we'll speak about shortly, a minimal important difference, which can help enhance the interpretation of a prompt is available, maybe that will inform your choice of which results to use when multiple different results from patient-reported outcome measures measuring the same construct are used in an individual trial. And of course, when thinking about all of these different issues, this may warrant rating down for risk of bias in your systematic review as well. So how can we get information on these different patient-reported outcome measures? COSMIN is an initiative which essentially helps with finding and evaluating patient-reported outcome measures and core outcome assessments. And they have a database of systematic reviews of instruments. So if you wanted to know about the measurement properties for the SF36 or something like the WOMAC, which is a disease-specific instrument that assesses function, pain, and stiffness in patients with degenerative knee disease, you could query COSMIN's database and look up to see, has there been a systematic review summarizing the measurement properties of this instrument? And certainly, again, this will help inform your choice of which results to use in your evidence synthesis. So very briefly, I spoke about measurement properties, just to highlight these three different concepts. Reliability refers to the degree to which the prompt measurement is free from measurement error. So these are metrics such as internal consistency, the reliability, as well as measurement error. Whereas validity refers to the degree to which a patient-reported outcome measure measures the construct it intends to measure. So this is things like content, face, construct validity, structural validity, cross-cultural validity, criterion validity, etc. And finally, responsiveness refers to the ability of a prompt to detect change over time in the construct to be measured. So again, these are all the different measurement properties you would be concerned about when trying to select the best instrument or the results from the most trustworthy instrument to include in your evidence synthesis. So I've briefly mentioned interpretability. We'll talk about that now a little bit. So despite the increasing use of patient-reported outcome measures in research and clinical practice, one of the key issues that remains is the interpretability of these very subjective measures. So, for instance, if I told you that in a clinical trial evaluating the effect of a new intervention found that a change in quality of life in the treatment group is on average 5 points larger than the control, how would you interpret this? What is the magnitude of effect? Is this trivial? Is it moderate? Is it large? If I told you that that 5-point improvement in the treatment group relative to control was statistically significant, would that help in terms of your interpretation of the results? And then finally, is there any other information that would help aid interpretability? So here is an example. This is one of the trials that was included in the systematic review informing the clinical practice guideline of knee arthroscopy versus conservative management for degenerative knee disease. So this was the clinical trial conducted by Katz et al. It was published in NEJM in 2013. So quite some time ago now, but essentially they looked at the effect of knee arthroscopy on pain in 309 patients with degenerative knee disease. They found that knee arthroscopic surgery significantly improved KOOS pain scores. So the KOOS measures quality of life in patients with degenerative knee disease, and they found that the mean difference was 7.5 points. And so the intervention group improved the KOOS pain scores by 7.5 points, and that was statistically significant. Again, the question that I pose to you is, what is the magnitude of effect? We know it's statistically significant, but is this trivial? Is this small but important? And is this large? And you can imagine that in the context of making recommendations or even clinical decision making, we need to think about the magnitude of effect when making recommendations for a particular intervention. So the next part of this talk is to really talk about what are the different strategies for making results interpretable in clinical trials, and then we'll also talk about different strategies for making results interpretable in systematic reviews. This leads us to the concept of the minimal important difference. So the minimal important difference, by definition, is the smallest difference that patients would consider important. There are a couple of different types, or I should say methods or approaches to determine minimal important differences. I will focus on anchor-based minimal important differences, and I will tell you why in a moment. But an anchor-based MID is an approach where a patient-reported outcome measure is compared to an independent standard, another instrument, which is called the anchor. An example of this is a transition rating, and we will go through an example. But it is important that if you're going to be using another instrument to determine the MID for your PROM of interest, that the anchor is something that is understandable and it's relevant to patients. So for instance, it measures symptoms, disease severity, or response to treatment, and it's not something like a surrogate outcome measure. So these are the two methods or approaches for determining minimal important difference. There are anchor-based MIDs and distribution-based MIDs. Anchor-based MIDs, I have just told you, rely on comparing the patient-reported outcome measure of interest to an independent standard. And it is a concept that really reflects patient importance in its methods, whereas distribution-based methods, and some of you might be familiar with seeing in the literature folks referring to an MID as half a standard deviation of the patient-reported outcome measure in an observational study or even in the context of a randomized controlled trial. Distribution-based methods really compare data with a change or observed change with variability. So it reflects statistical characteristics of the sample and is not at all informed by importance or what is important to patients. And for that reason, we consider it to be a lesser approach to determining minimal important differences. And so the focus of this talk today will really be around anchor-based methods. And I would almost argue that nobody should be using distribution-based methods for determining MIDs. And as we are systematic reviewers in this context, I would argue that we should not be using MIDs that are determined using distribution-based methods to inform interpretation of patient-reported outcome measures because they do not reflect patient importance. They are simply just statistical characteristics of a sample. So here is an example of an anchor-based method for determining a minimal important difference. So in this case, we conducted a study where we were looking at breast cancer patients undergoing breast reconstruction. And the instrument is something called the breast-Q, which is a breast reconstruction questionnaire that asks patients about their breast reconstruction after surgery in terms of feeling, sensation, appearance, and other constructs as well. So in this case, the anchor or the measure that we have used to determine the MID for the breast-Q is a transition rating item. So what is an example of a transition rating item? Well, this is a perfect example of one where the transition rating item asks, how has the feeling in your breast area changed compared with your 3-month post-operative visit? And patients will say either, it's a little less, I have a little less feeling, it's about the same, or I have more feeling. Now, if they say less feeling, is it a small decrease in feeling and not very important to me, or it's a small decrease and it's important? Is it a moderate decrease in feeling? Is it a large decrease in feeling? Same thing with the patients who identify and say, actually, I have more feeling in my breast after the reconstruction. And they would similarly tell us, is it a small increase, not important, small increase, important, moderate, or large? So how do we put this all together? How do we actually derive a minimal important difference by using this anchor question? So as I said, we have a transition rating item, which is the anchor that we've just gone through, and I've put up the response options to the anchor in the right-hand corner here for your reference. And we can lump patients into groups. We can lump people into those who've had a moderate and large change, and this refers to patients who were classified themselves as moderate or large, -3, -4, or +3, +4, people who've had a small important change, and then people who have no change or an unimportant change. So how do we get the MID from this, utilizing this anchor? Well, if we focus on only those patients who say they've had a small but important change, and we take the corresponding mean change of the score on the breast-Q domain, the difference between time 1 and time 2. So this is done over a longitudinal period over 3 months, because that is the duration over which we've asked patients how their breast sensation has changed. If we calculate the difference in breast-Q scores over 3 months in those people who've had a small but important change, that will give us our MID calculation. This is referred to a specific method for calculating the MID called the mean change method. There are various different statistical methods that can get very complex, but this is probably the most intuitive way one can conceptualize how an MID is calculated. And to summarize, you take patients who self-identify as having a small but important difference on an instrument that is quite intuitive, like a transition rating item. It's a single question. And you use those patients who identify as having a small but important difference to figure out what is that small but important difference, or the MID, in the index instrument, in this case, the breast-Q questionnaire, which is a questionnaire that consists of 20 or 30 questions and is not as intuitive to interpret. And that is how we derive an MID. So once you have an MID, how can this be helpful? How can this be helpful for interpretation of patient-reported outcome measures? So we'll focus on the clinical trial setting initially, and then we'll talk a little bit about how we can enhance interpretation of patient-reported outcome measures in systematic reviews. It's important to understand this at a clinical trial level because we're dealing with primary data before we can understand how can how can we employ different strategies to enhance interpretation in the systematic review context? So we'll deviate from our example of arthroscopic knee surgery for degenerative knee disease to another example where there was an RCT conducted of lung volume reduction surgery in patients with severe emphysema or chronic obstructive pulmonary disease. There is some evidence to suggest that reducing lung volume may improve mechanical properties of the lung. There was an RCT of 55 patients, very small RCT, followed for about 1 year. Patients were followed for about 1 year, and the key outcome was quality of life assessed by the chronic respiratory questionnaire. And this looks at dyspnea, which is shortness of breath, fatigue, and emotional function. So this is how an MID can be used to interpret the results of this clinical trial. So here you will see the effect of surgery and medical treatment. So this arm here is the surgery group, this is the control group, I believe, and this is the surgery group. And you can see here that there's clearly an improvement at each time point up until 12 months, where surgery has improved emotional function in patients who've undergone this surgery, lung volume reduction surgery. And this is where the MID can be helpful. So you can see the shaded area represents the MID, which is 0.5. So you can see that each point, not only is the improvement statistically significant, but on average, at each time point, the difference has exceeded the minimal important difference. So while this is helpful, there are some challenges with interpreting the data in this way, where you compare mean differences to an MID. So if we assume in this case the MID was 0.5, and patient's mean improvement versus control is about 0.25 on the CRQ. Does this mean that nobody benefits? So if the mean difference, the MD is 0.25 and the MID is 0.5, does this mean that because the mean difference falls below the MID, does this mean that absolutely nobody benefits? Well, that's not true, because we know that we're speaking about average effects. Similarly, what if the mean difference was 0.6? Does that mean now, because it exceeds the MID of 0.5, that everybody benefits? Again, that's not true, because we know that 0.6 is on average the mean difference. And similarly, if we think about the example of a mean change of 0.25, that could mean that 75% of people have zero improvement and only 25% have an improvement of 1. So there are certainly limitations with comparing mean differences to an MID. It is helpful for interpretation, but there is that susceptibility to naive interpretation. And so we need to be mindful of the interpretations that we are making when considering that method for interpretation of patient-reported outcome measure. Another way in which we can use the MID is we can use the MID to dichotomize. So if you can imagine, these were the results of the change in CRQ score at a given point in time. And this is the data. You can see that it's pretty normally distributed. If you landmark the MID being here, you can actually, is of 0.5, which we have just mentioned. You can calculate the proportion of patients that have experienced an improvement greater than the MID and those that have the proportion that have experienced an improvement less than the MID. You can use this information to calculate or to do a responder analysis, also known as the proportion of patients who have experienced an improvement greater than the MID or less than the MID. And then you can subsequently use this to calculate, apologies here, my slide is not advancing, there we go. You can use this to be able to calculate a difference in the proportion experiencing the improvement greater than the MID and less than the MID in each group, and then similarly calculate a risk difference, or you could also calculate a risk ratio, a risk difference, as well as a number needed to treat. So this table nicely summarizes what we've just gone through, which is the difference, the mean difference between groups, and you could consider what the MID is, and then this responder analysis, and then finally in this last column, the number needed to treat. So these are two very clearly distinct examples of how we can use the MID to interpret patient-reported outcome measure data, comparing the MID to a mean difference, but then also using it for a responder analysis. So now we can pivot and talk briefly about how we can use the MID in systematic reviews and meta-analyses. So there are a couple of different situations one might find themselves when conducting a systematic review, and we have patient-reported outcome data. And we'll go through a real-life example where this posed a few challenges for the systematic review team informing the clinical practice guideline. So you might find yourself in situations where all of the clinical trials you're including in your evidence synthesis use the same or similar outcomes. So what are the options when you find yourself in that situation? Well, that seems pretty straightforward. All the trials are using the WOMAC, or all the trials are using the CUS, which are different patient-reported outcome measures. If that is a situation that you find yourself in, you could very easily compute a weighted mean difference in natural units of the patient-reported outcome measure scale. And you could do exactly what we've just gone through for clinical trials. You could do so similarly for systematic reviews. You can calculate a weighted mean difference and compare the weighted mean difference to the MID, or even do a responder analysis. You might be wondering, well, how do you do a responder analysis when you're using clinical trial data, which is aggregate level information? You can model the data. You can model a weighted mean difference, assuming a normal distribution in the data and equal variances. This is where the statistic gets a little bit heavy, but there are ways to model the data to conduct responder analysis on clinical trials data in systematic reviews. And there are a few different resources that I will point you to in this talk as well. But again, if you find yourself with all the same patient-reported outcome measures being used in all the clinical trials, that is a very straightforward situation where you can easily compute a weighted mean difference or do a responder analysis and use the MID for interpretation. What if you find yourself in a bit of a different situation, where you look at the clinical trials included in your evidence synthesis, and it turns out they're all using different patient-reported outcome measures? Well, this is exactly the situation we found ourselves in when we were conducting the systematic review informing the guideline. So we found that for pain, there were, maybe about 8 different instruments. Same thing for physical function. Thankfully, for the quality of life, all the clinical trials use the EQ5D. So the question really is how do we deal with this situation now? What do we do when the clinical trials are using different patient-reported outcome measures, and how are we going to aggregate this information and synthesize this information? So when studies are using different outcome measures, we need to rely on different methods or different strategies for presenting data in meta-analysis and summary findings tables, and how we are actually going to interpret this information. I've listed here the different methods that folks should be familiar with. So when you are dealing with different instruments from different clinical trials, there are different strategies. The first many of you will be familiar with is the effect size, Cohen's effect size, or a standardized mean difference. I will argue that this is probably my least favorite method, and the reason being is that it's vulnerable to population heterogeneity. So folks, very briefly, recall a standardized mean difference is calculated by taking a mean difference and dividing it by your standard deviation. For the same for 2 different clinical trials with the same underlying treatment effect, if your standard deviation, if you have a very homogeneous sample, you're going to have a very small standard deviation. And if you have a very heterogeneous sample, you'll have a larger standard deviation. And so for 2 same or similar effects, treatment effects, you can get very different standardized mean differences. So that's the biggest problem with the standardized mean difference. The other major issue with it is that it's very difficult to interpret. We have something called the Cohen effect size rule of thumb, and 0.2 is a small effect, 0.5 is a moderate effect, and 0.8 is a large effect. But that rule of thumb, essentially has been just made up, and it doesn't actually reflect what is important to patients. Again, it really has to do with underlying distributional characteristics of the sample. Another way that you can synthesize this information is you can put the instruments into natural units. So you might say, well, how do you do that if all these instruments there's multiple different instruments being used across the different clinical trials? You can, with some underlying assumptions, convert all the data to a single instrument and be able to pull the data that way. You could dichotomize the data, as we've talked about in a responder analysis. Again, you can transform the data all onto one scale and then use an MID to dichotomize data. You can also calculate a ratio of means. So this is just the mean in the treatment group divided by the mean of the control group. It's not a method that's very commonly used, and many people are not familiar with it. Again, it has issues with the interpretation. It's not very intuitive. And then finally, you can calculate a treatment effect in MID units. So this is kind of similar to a standardized mean difference, where you take the treatment effect or the mean difference and you divide it by the MID for each instrument. This requires you knowing the MID for each instrument included in your systematic review, which sometimes can be a bit challenging, especially if there's no MIDs available. All of these different methods have been reviewed and proposed in the GRADE Guidelines 13th paper on preparing summary findings tables and evidence profiles for continuous outcomes. So I've gone through those very quickly today, but there are certainly resources, and I'm happy to share these slides later for folks who are conducting this type of work. And the GRADE Guidelines paper was based on this paper done by Christian Thorlin and a few other folks on pooling health-related quality of life outcomes and meta-analysis. So this is a tutorial that goes through all these different methods for enhancing interpretability. So we'll briefly talk about, in the last few minutes here, talk about identification of MIDs. So we've talked about how the MIDs can be extremely helpful for enhancing interpretability. So you might wonder, well, how do I find these MIDs? We've talked about, well, anchor-based MIDs are best, but how do you actually identify these? And if you're somebody conducting a systematic review of treatment effects, this requires a whole other effort to identify MIDs that are going to help enhance the interpretability of patient-reported outcome data in your systematic review. So you can conduct a systematic survey of the MID literature. So for the RapidRec guideline, this is exactly what we had to do. We had to go and identify all the patient-reported outcome measures that were being included in the systematic review of treatment effects and find MIDs for every single patient-reported outcome measure. So you can conduct a systematic survey. This requires identifying the relevant constructs, the outcome measures, the population of interest, the interventions, and any other contextual factors that might be relevant when selecting an MID. This is a systematic survey that was published a few years ago of minimal important differences for patient-reported outcome measures that our group has published in JCE back in 2021. It's essentially an inventory of every MID known to humankind for every patient-reported outcome measure published in the literature. And this is the basis for developing PROMID. So PROMID is a database of minimal important differences. We have over 1,100 MID estimates for estimation studies, and then over 7,000 MID estimates for over 600 prompts. So it requires a lot of effort to conduct a systematic survey to identify MIDs. An alternative would be to look at PROMID and query the database to see if you can find MIDs for the particular patient-reported outcome measures included in your evidence synthesis. Just a brief word on credibility. So as I mentioned, no two MIDs are created equally. So we have developed a credibility instrument so you can assess the risk of bias of MIDs when selecting an MID to inform your interpretation. We won't go through the details here, but if one was interested, we have published this in a paper in the BMJ back in 2020, and this is a credibility instrument that one can use to, again, assess the credibility and make appropriate choices of MIDs. And this is just an extension of this guidance. We created an additional item for those that are, again, interested. Just a brief word on selecting the optimal MID. So as I alluded to at the outset of this presentation, unfortunately, no two MIDs are created equally. Similarly to how we conduct trials and systematic reviews and guidelines, methods are very important. And folks are doing there are various different methods that are being used to determine minimal important differences, and it's important that we pay attention to how these MIDs are being derived. So we've talked about credibility. Is there another aspect that we should be considering when selecting an MID? There is some evidence that suggests that contextual factors can influence the magnitude of the MID. So I'll give you a very quick example. When conducting the systematic survey of minimal important differences that we provided to the systematic review team to inform the clinical practice guideline, we actually found that on average, MIDs that were developed or derived in patients who were undergoing surgery were on average about 2.5 times larger than MIDs that were determined in patients who underwent conservative treatment. And that might not be so unreasonable to think that the MIDs or the expectations around surgeries, what one might consider a small but important difference, would be larger in patients who are undergoing a treatment that is more invasive and has more risk associated with it and involves a longer recovery period. So that's just one example of where a contextual factor, the type of intervention, could influence the magnitude of the MID. So when selecting the optimal MID, two important considerations are the credibility and then the contextual factors or the applicability, for those familiar with grade, analogous to indirectness. And this is we've created a step-by-step approach for selecting an optimal MID, which again takes into account both credibility and applicability. I recognize I'm just a few minutes over time and I will wrap it up now. So just going back to the case. So how did we put this all together? We had a systematic review team that have identified the evidence and summarized and synthesized it. We recognized that there were challenges with interpretation of the results of the data. We decided to use presentation approaches that have been previously developed by folks that I've mentioned and has been summarized in the grade guidance to help our panel, our guideline panel, make a recommendation. And that involved identifying minimal important differences. Those were the presentation approaches that we thought would be best to help inform these recommendations. And that required us to do a systematic survey of MIDs for all the patient-reported outcome measures that were included in the systematic review. But how did this ultimately help? So this is a nice figure that's the BMJ graphics. They do a great job of summarizing the results from the systematic reviews informing the guidelines, and you can see here that on average, the mean improvement in function for arthroscopic surgery was 13.3. For conservative management, it was 10.1. The mean difference was 3.2. We know that the MID is 8, and so we know that on average, most patients were not experiencing an improvement that was greater than the MID. It was actually far less than the MID, less than half the MID. Similarly, there was a responder analysis done, and it showed that about 98 in 1,000 people more would reach the MID with arthroscopic surgery compared with conservative management, whereas the other 902 out of 1,000 patients would not benefit from arthroscopic knee surgery. And so putting together, this is a summary of all of the different outcomes. So again, they looked at both pain and physical function. They also looked at harms, including VTE as well as infection. But putting together all of this information, considering the MIDs, and considering patient values and preferences. This is considering the inconvenience with conducting surgery, the cost of surgery, as well as a recovery, all that putting together, the panel made a strong recommendation favoring conservative management and making a strong recommendation against arthroscopic knee surgery in patients with degenerative knee disease. And with that, I will stop there. Again, I apologize. I went just about 4 minutes or so over time, but I'm happy to take questions. And again, happy to share the content and these slides. As I understand, there is a lot of information presented here today.
Thank you, Tahira. Very clear presentation. No worries. We have a couple of questions that I would like to share with you. When you have time, while we are answering the question, Tahira, if you are able to provide the links to the key papers that you have provided in the presentation, that would be great. So for people can direct access. So one first question that we have here, Tahira, is about how to interpret, for example, a quality of life result when it is evaluated with multiple tools that supposedly evaluate the same construct. But in some tools, there are significant differences, and in others, there are not.
Yeah, so that's a great question, and certainly sometimes you will see that, right? So, am I still sharing my screen or not anymore?
You are sharing the screen, and the next question may require to share the slides again, so don't
Sure.
stop for
Okay,
now. Okay.
so you can still see my slides here, yes?
Yep.
Excellent. Okay. So this is a, perfect example. I don't have, in this case, I don't have the exact example of the question that is being asked. So just to summarize, the question being asked is when you have multiple tools that have seemingly different results. So some of the instruments are saying there's, a treatment effect, and some of them suggesting that there's no significant difference. In this table, so this was the example that I had shared earlier in my presentation, you can see here, and we're just focusing on the p-values, but the p-value here was 0.26, 0.93, 0.2, 0.58. So in this case, it's really easy because none of them are showing that there's any, significant effect in undergoing surgery versus conservative treatment. So the question is that what do you do when the results are different and there's disconcordance? So this is where you need to consider, how should you select the results? Should you be selecting the results based on the results? Absolutely not, right? We're not going to cherry pick, the results that have a positive effect or a negative effect based on the message you want to convey, right? So this is where you need to, what I would recommend is if you are looking at these these 4 different instruments, the WOMAC physical function, the SF36, the ASES function, the MAC-TAR, what I would do is I would go and I would look at the measurement properties. How valid, how reliable, how responsive are these instruments? Which one is most trustworthy? Because again, depending on their measurement properties, they may not be sensitive or responsive enough to be picking up a treatment effect when there is one. So that would be a place that I would start. Again, another thing to consider is some of these other factors. So the measurement properties, the construct, so making sure that what's actually being measured in the instrument is the same construct you intend to measure as somebody who's conducting the evidence synthesis. So function can mean very different things. Physical function, emotional function, there's many different interpretations of function. So I would look at the content of the questionnaire and making sure that you're picking the same construct. One other thing to consider is in this example, the SF36, most of us know that, this instrument is a generic instrument. So there might be some noise between a generic instrument versus a disease-specific instrument, the types of questions that are being asked in the questionnaire. So that might be something to consider, is whether or not, again, the instrument is sensitive enough to pick up an effect, a treatment effect, if it's truly there. And then finally, I would also think about, is there an MID available? Because if there isn't an MID available, that might make interpretation of the results to be challenging. But I would really focus on the measurement properties and, what is the most valid, reliable, and responsive measure. Does that answer the question?
I think that answers the question, unless we get any other idea from the chat, but I think that answers the question. Tahira, there was one person from the audience that didn't quite understand the example that you gave with the MID of 0.5. In the result that you presented, it was 0.25 and then 0.6 or 60. So you were mentioning about the mean of the results. So I don't know if you can go back to that specific example to see.
Sure, absolutely.
Yeah,
So this
yeah,
is the example where we said the MID for the CRQ, which is the chronic respiratory questionnaire, is 0.5. So what I was trying to convey here is saying that if we take the results of this RCT and the mean difference between treatment and control at, let's say, 6 months is 0.25 on the CRQ. So if we think about that, that is half of the minimal important difference. So if we say the MID is 0.5, the mean difference is 0.25, what I was trying to convey here is that that's half an MID. So will we say that nobody has benefited? Well, that's not true, right? Because we could have, again, 75% of people can have a score of 0, and 25% of people can have a score of 1. So what that means is that even though the mean difference is 0.25, 25% of people can easily have a mean difference that is double the MID. So it's just to show you that using the MID to interpret mean effects is susceptible to a naive interpretation. Similarly, if the mean difference is 0.6, we wouldn't say that everybody is having an improvement that's greater than the MID of 0.5, because again, this is just a mean. And again, there are going to be some people that are certainly going to have improvements that fall below the MID of 0.5.
I think that's more clear from the people for the people. Thank you, Tahira. There is another question about the use of the anchor base, distribution base. You were very clear about the preference of anchor base instead of distribution base, but there is also the option of doing like a consensus expert approach to see what would be the potential MID. Because it is common in some contexts, in some fields, that you will not have an MID. Your approach is easier when you have an MID. And that is very common, let's say, for instance, in rheumatology, yeah, quality of life or pain maybe. But in other fields, like for instance, in pediatrics, we may have a lot of scale that don't have an MID. And would you think that people would kind of consider use this distribution base if there is one, or it might be better to do a consensus-based approach with experts to see what would be the potential MIT to do an interpretation in the context of a systematic review and in the context of a guideline? What are your thoughts on that?
Yeah, I think it's a good question. I would lean towards a consensus-based MID over distribution-based, because at least in a consensus-based approach, you have people who are experts. I think with any panel, whether it's a guideline panel or a consensus panel on choosing an MID, it's important to have broad stakeholder representation. So, having experts in the field, having patients with lived experiences, I think would be very beneficial in the absence of an anchor-based MID that has not been empirically derived and not available. I would much prefer a consensus-based approach because, again, it provides a perspective. People who have experience with the illness, people who have experience with treating the illness, as opposed to, again, relying on half of a standard deviation of the score in a sample of patients. Because again, the distribution-based approach really doesn't reflect anything to do with importance. It has to do with characteristics of the sample. There has been some work that has actually looked at, how does a distribution-based MID compare to an anchor-based MID, and there's no consistency in the results of whether or not the half standard deviation typically mimics or will be similar to an anchor-based or an anchor-based derived MID. So because of that, I'm very reluctant to use a distribution-based MID. And if you have the ability and the opportunity to get a consensus-based MID, that's what I would do.
I see. Thank you, Tahira. I think we are running out of time. You would like to, I have shared in the chat a couple of your papers. I already have it at hand. Both the BMJ and the JCE. So for people to have access to them in case they want to provide more, to have more information. I also provided a link to the PROMIT website. So for people can have it there. And in case you want to share anything else or you want to add anything else from people who are now attending here, like clinicians, experts, systematic reviews and guidelines, you have provided another one there?
Yes, I will throw a few others in the chat. This is just the BMJ rapid recommendation.
Okay.
And the MID review if folks are again interested. And Yvonne, I'm happy to again share the slides, and I can even send you a list of the full reference list as well for all the papers that I've shared as well.
Awesome. Thank you so much. Okay. With that being said, while I do the final wrap up, if you want to share anything else there in the chat, go ahead. Thank you so much, Tahira, for your willingness to help us, to join us, to provide your experience in MID for the audience here in Cochrane, Colombia. There were people also connected from different outside of Colombia. And this has been a very exciting summary of your work and all the challenges that we have in MID. Thank you, Tahira.
Thank you again for having me, and happy if anybody would like to reach out. I've put my email up there as well. If anybody has any questions, I'd be happy to connect with you offline.